Okay, IV fluid, tonicity, and types. So before you start talking about different types of IV fluid, you really want to think about why does your patient actually need IV access or IV fluid infusion. So obviously, if they're vomiting, they can't sustain enough fluids to, to keep their fluid balance maintained. They would need an IV and maintenance IV fluid. Electrolyte imbalance, definitely, we have to maintain that cellular equilibrium. Glucose, if they don't have enough sugar for metabolism, we've got to give them sugar in order to give those cells what they need. So medications, obviously, especially like with our heart failure patients that don't necessarily need IV fluid running, they just need IV access to possibly give diuretics. An IV fluid, and then again, kind of like that lifeline for rapidly needed medications if they're at high risk for needing IV medicines quickly. That also kind of raises the point of what is an IV fluid rate that's fast, that's slow, that's normal. So to really think about that, normally on a day-to-day basis, we take in about 2,500 intake and output equally. So if you have someone that is NPO, let's say for surgery, and they just need IV fluid maintenance to sustain exactly where they are. So if you think about it, let's just go with 2,400 because that's a good 24-hour rate. A normal IV fluid rate to maintain fluid status is going to be around 100 an hour. If they are hypovolemic, common sense would lead you to believe your IV rate might be 150 or even faster an hour to replace lost fluid if they are low. But it also, if let's say they begin to start eating and drinking, they will taper off that fluid. So you're probably going to see a number less than 100. So maybe like 75 or 50. And then hopefully, they would keep an eye on that and stop the maintenance IV fluid. Okay, so categories. You've got your crystalloids. They manage fluid using osmotic pressure, so mainly from the sodium exchange, where we know the sodium goes, the water flows. So they use the difference in osmotic pressure. Colloids are going to be larger molecules. They use oncotic pressure as to increase volume into the vascular space. So they actually pull fluid into the bloodstream. Example like albumin, it's a thicker, it's heavier, larger molecules, and they tend to draw fluid in from the interstitial space into your blood vessels. Hespan, it's Hes starch, it's also called Hespan, dextran, fresh frozen plasma, all of those things have larger molecules, so do a fantastic job of pulling the fluid in. Okay, I'm sure you've seen this slide before in previous classes. Just to touch on tonicity, our hypotonic solution does a fantastic job causing our cells to swell. So if you have a patient that has dehydrated cells that might look like this type of cell, you would maybe want to give them a hypotonic solution to increase the size of those. Isotonics do absolutely nothing to the size of the cell. They are exactly the same tonicity. Hypertonic solution, they are going to cause our cells to shrink. So if you have someone who has cells that look too enlarged, might be good to get a hypertonic solution to help shrink those cells back into the normal. So this is the goal for every cell. So it just depends on where they are to begin with. Okay, so we'll kind of start with the different types of tonicity type IV fluids. So our isotonic solutions, 0.9 normal saline, lactated ringers are the two best examples. Their range in serum osmolality is 240 to 340. So if you remember, our normal human serum osmolality is 280 to 300. So you kind of keep that 300 range as your normal, that is obviously, it's not going to change anything with the cell. It's just going to, expand our volume, possibly replace some water or electrolyte loss. Excellent medication or excellent IV solution for just diluting medications. This is a fantastic solution for someone who you might, if you're assessing they are hypotensive plus symptomatic. So you can give a lot of IV fluid in a hurry here with isotonic solutions because it's exactly the same consistency as your actual blood cells. Okay, 0.9 normal saline is probably the most benign solution you could imagine. 304 osmo, which is right there in the middle. for our normal human serum osmo. So a lot of times we will use this to increase vascular volume or volume resuscitation. So when you hear the term resuscitation, that's going to be quite a bit of fluid in a hurry. We know that we can give this with blood. So not necessarily with blood, we're going to prime our tubing, obviously, and then you will use this to then rinse the tubing. So 0.9 normal saline is isotonic to blood, so that's the only solution you can give, along with the same time as blood in the tubing. Fluid challenge. So sometimes your patients, let's say their urine output has been running low, less than 30 milliliters an hour for a few hours. They can give fluid challenges. So maybe 500 milliliters of 0.9 normal saline over maybe an hour, and watch, hopefully that urine output will kick up depending on their metabolic state. Um, so anyway, fantastic for patients who are, symptomatic and hypotensive. Wonderful IV fluid. Okay, lactated ringers, very similar to 0.9 normal saline. The only difference is, or the one big difference is 0.9 normal saline has no electrolytes at all. It's just simply a sodium solution. Lactated ringers does have just a little bit of electrolytes there. So there's a little bit of sodium, chloride, lactate, potassium, and some calcium in there. Very similar to what is normal in our blood stream. The liver converts the lactate to bicarb, so this is actually a really good solution if you have someone who's in a mild metabolic acidosis. That little bit of bicarb can help kind of turn it around. So great for burns, post-op fluid, blood loss, shock. Again, this lactate is converted to bicarb, and so we're going to be a little bit hesitant to give that with someone who's got severe liver disease, because the liver is what actually converts that lactate, and so we wouldn't want to overcome the liver with too much lactated ringers. Okay, so moving on from isotonic, we're going to then start talking about hypotonic solutions. So oncotic pressure is used to draw water into the cell from the extracellular fluid. So the way I kind of am very visual in how I think of things, think of a shriveled up cell, maybe that kind of looks like a raisin. You put this raisin in a big bucket of point or half normal saline, quarter normal saline, or we're going to talk about dextrose and water here in a second. But it is a hypotonic solution. So it is going, put that in there for about 5 minutes. It's going to pull fluid into that raisin. It's going to make it look like a perfect little grape. But the thing we want to consider is, when is it time to take that grape out of the water? Very big danger we can have is causing cellular edema, and especially increased intracranial pressure. Our brain is a closed, we have our skull. And so we would not want to give hypotonic solutions for a long, long period of time beyond what our patient needs. We want our cells to be just right, not overinflated. And back to dextrose and water, it's one of those mystery type solutions. It's got a 250 serum osmo, but which, if you remember, normal isotonic is 240 to 340. So it falls in a isotonic, but the second that dextrose is infused and our bodies convert the glucose, then all you have is free water, which is hypotonic. So it acts as isotonic for a short period of time, and then it is considered hypotonic because all that's left is free water after the glucose is metabolized. Okay, just a little bit on hypertonic solutions. The best example I can use to support this topic is if you have a patient with hyponatremia. Say their sodium is 115, 119, and when we discuss sodium imbalances can cause lots and lots of metabolic problems. We can infuse a hypertonic solution, so a 3%, 5% very concentrated sodium solution. Thing you always want to remember about hypertonic solutions is we want to use these with great caution. They're very concentrated, and they generally are going to be giving at much, much slower rates. Here, if you look, we can cause circulatory overload pretty quick. We should always be giving these with a IV pump, most likely a central line if at all possible. But these are going to be given very slow because it's going to cause our cells to shrink and the extracellular space to expand. So we want to watch our patients' fluid status very closely with hypertonic solutions. Review question answer. Hypertonic solutions can cause fluid to move from the B, hypertonic intracellular space to the extracellular space. Module 2 review question. That's D5W. If you remember, as soon as we metabolize that glucose, it becomes free water. Okay, IV solution. Next question here. Critical thinking question. What are we worried about with lactated ringers? Can we give it with blood? No, we cannot. That's only 0.9 normal saline. Solution to choose to expand volume in patients with severe liver disease? No. If you remember, it's metabolized in the liver, so we would put the liver into liver failure. It does, yes, that's a yes for C because it does have a small amount of potassium. It may contribute to lactic acidosis. That's a no. It actually may contribute to lactic metabolic alkalosis because it's converted to bicarb after it is converted to that into the liver. Okay, our last question. A patient with a stroke arrives to the emergency department. The physician prescribes normal saline at 70. We like that because it is isotonic. We do not want our brain tissue to swell. If we gave a hypotonic solution, it could cause our cells to swell, and that brain, again, is a closed space. So isotonic is very good with any sort of brain injury, patient, stroke, any sort of someone you're worried about intracranial pressure with.